Hello, everyone, and welcome to Interview with the Experts. My name is Alan Lewis, and I am an Associate Professor of Medicine at Mayo Clinic. I'm joined together by my colleague, Dr. Rosalyn Adigun, who's one of our advanced heart failure and transplant cardiologists with a special interest in cardiac amyloidosis. So thank you very much, Dr. Adigun, for joining us.
Thank you for having me.
What we were hoping is maybe you could start by providing us with a bit of an overview of what is amyloid.
Oh, thanks, Dr. Lewis. So, amyloidosis is a broad spectrum of diseases that result from misfolding of proteins. And these proteins aggregate into forming fibrils. So the fibrils are actually what invade the intracellular cells of any organ, essentially, and cause an end-organ dysfunction. Additionally, most amyloid, not all, could be toxic and also cause some injury to the cell to the tissue where they infiltrate. Interestingly enough, amyloid has been around for a while. In the 1800s, it was initially considered an autopsy finding and described in the literature as waxy and gelatinous. And initially, because it's stained with iodine, it was thought to be a starch. And I think we can all appreciate the 1800s is the evolution of microbiology and histology. And the characterization of this structure actually made it known that this was actually a protein substance. And since then, they were able to subtype it and see that this is a protein. And actually, there are different subtypes. And right now, there are over 30 amyloidogenic proteins that we know that cause disease. But I think for the sake of our discussion, we'll focus on the two most common ones, which are the hemoglobin light chains, AL amyloid, and the transthyretin amyloidosis that tend to affect the heart. Why cardiac? We all know that cardiac involvement with any form of amyloid usually is a poor prognostic indicator. And that's why a lot of emphasis is placed on this, because earlier identification and treatment improves outcomes.
That sounds great.
Thanks.
Maybe you can tell us a little bit more about how do we identify and treat these patients?
Absolutely. So one of the biggest challenges that has plagued the amyloidosis community, and I think we're doing so much better now, is how do we identify the patients early? Why does this happen? Most patients present with nonspecific symptoms. And we know we've all been in clinic where patients come in, they don't feel well, they're short of breath. And a lot of times we think of a lot of things, but we don't think of amyloidosis. And even as providers, we've learned about amyloid, maybe when we're in medical school, but you typically don't see it, and we've been far removed. But in the last 10 years, there's been an evolution in imaging modalities. And now with the approval of therapies to treat it, we're seeing more patients present. So how do we identify these patients? I always like to think of clinical indicators and imaging factors. The reason why that's important is this: patients present with clinical symptoms, and a provider has to think of amyloid, because if you don't think of it, it's easy to miss. So I always say when patients present with heart failure symptoms and you start the evaluation, maybe you look at an angiogram, there's no obstructive disease, or they present with maybe other non-specific symptoms like fatigue, shortness of breath, and you try to interrogate their other clinical history, and you see things like maybe they've had arrhythmias, or maybe they've also had some red flag symptoms that we talk about. That would be something like, has this patient had carpal tunnel? And I think that's a big one. Some of these patients, a median of about 7 to 10 years before they present with overt heart failure symptoms, they might have carpal tunnel neuropathy, atrial fibrillation, spinal stenosis. So when you start to see those associations, that should pique your curiosity to look out for amyloid. Something else that has happened, I think, in our society is because of the accessibility of echocardiogram and imaging in general, patients actually come to diagnosis by getting an echocardiogram or some imaging in the setting of maybe evaluating them for a complaint, and we see some typical findings. So those typical findings in the right clinical context is another way that we also have patients present to our clinic. So what are those findings? We always talk of increased wall thickness. But I want to caution people, because increased wall thickness can be for a number of things. So it has to be in the right clinical context. I would say if you have a patient with no other alternative explanation for the increased wall thickness, think amyloid. Something else that we also like to say in imaging is increased wall thickness, reduce annular velocity that shows that the myocardium itself is quite abnormal. And then we talk about a speckled appearance. And the amyloid fibrils, they reflect a kind of a sheen, a waxy look that catches your eye. So thickened walls, reduced annular velocity, the speckled appearance of the myocardium. And more importantly, I know people think of this a lot, and is one that people tend to catches people's attention, is the abnormal global longitudinal strain that has an apical sparing pattern. You see those signs, imaging indices, in the right clinical context, think amyloid. The last thing I would like to say is this. We all have some patients we see in clinic, maybe they've had hypertension for years, and you find out that for some reason, that patient is no longer tolerating their medication. They're starting to be hypotensive, they don't feel well. Autonomic dysfunction is another big clue. So I say clinical findings, imaging findings, and then one other thing, laboratory biomarkers. So remember I said these fibrils can infiltrate into the intracellular space and cause injury. In cardiac amyloidosis, you start to see abnormal cardiac enzyme biomarkers, troponin, and also you see the NT-proBNP, which is indicative that there's some increased wall stress of injury. Those indices should always pique our intrigue and make us think of amyloid.
That sounds good.
Thank you.
You mentioned echocardiography as sort of investigation. You sometimes want to escalate investigations from there to make a more definitive diagnosis. Do you mind talking a little bit about cardiac MRI, that nuclear PYP scan that we hear often, cardiac biopsy? Who, when should we do these things?
Great question. And I think you ask a very important question that we like to educate providers who see these patients, because following the diagnostic algorithm would help you not miss the diagnosis or mistype the type of amyloidosis that have dire consequences. So when you have a clinical suspicion that a patient has amyloidosis, one of the first steps is, or maybe they have an imaging, is get imaging modality, an echocardiogram or a cardiac MRI. So there are certain features on the echocardiogram, which I referred to earlier, that will pique your curiosity. And on the MRI, what we see is some abnormal kinetics of the myocardium, difficulty nulling the myocardium. We see edema as well. So you look at the extracellular volume. Those things will also be very suspicious for amyloidosis. While those are good initial tests, one thing that I have to emphasize is cardiac MRI does not tell you what kind of amyloid there is. So when you have a clinical suspicion and you have imaging, echo or MRI, the next critical step is that you screen for monoclonal proteins. And we want this to be very important, because screening for monoclonal proteins will help you identify the immunoglobulin light chain form of amyloidosis, which we refer to AL amyloid, which has a very different pathway for treatment as opposed to ATTR transthyretin amyloidosis, which is transthyretin, which is manufactured in the liver and is treated separately. So once you get the monoclonal, when you screen for the monoclonal proteins, if you do find monoclonal proteins, then you go down a separate algorithm, a separate path down the algorithm, where you now get a tissue sample, because in those patients, we need either bone marrow biopsy or fat aspirate, and that would help identify the amyloidosis. And subsequently, you also want to make sure that you are subtyping the kind of amyloidosis. Why is that important? You can have a monoclonal protein. That could be a monoclonal gammopathy of undetermined significance that we have to follow, and that sometimes are called concomitantly in patients with transthyretin amyloidosis. Now, in the other pathway, you have screened for monoclonal protein, and it is negative. Then the next step would be scintigraphy. Like you rightfully mentioned, in the United States, we use the pyrophosphate scan, and we have a visual assessment as well as other quantitative assessment of uptake in these patients. So once you have a patient with a clinical suspicion, the initial imaging test, and you screen for the presence of a monoclonal protein, the next step would be, if that screen is negative, then you can proceed to a PYP, a pyrophosphate scan, to assess quantitatively and visually. The one thing we also say, because there are numerous protocols out there, is that when you do perform these, we like that performed with SPECT imaging. That becomes very important, because we don't want to misdiagnosed patients where we see uptake that could represent the blood pool. We want to make sure the uptake is in the myocardium and really assess and get a good quality study. So once you do that, then a question that can come up is, can you have a negative scintigraphy scan and still have amyloidosis? See, I'm a mind reader now. So it is possible, and we know that some fibrils stain better than others. So what we always say is that, back before the evolution of imaging in the area of amyloidosis, a lot of times we did get endomyocardial biopsies. We don't do that as much anymore. However, in those situations where you have a high clinical suspicion, but the scintigraphy study comes back equivocal or maybe negative, you can proceed down to get an endomyocardial biopsy, because there are some patients that is the way you reach the diagnosis. But ultimately, when you reach a diagnosis, it becomes important to screen to see if the transthyretin amyloidosis is a variant form, which is where there is a mutation in the structure of the transthyretin molecule, because that would be important in terms of screening family members and increase awareness, versus if this is a wild type form of amyloidosis. Do we treat them differently? Well, there are certain drugs that have been approved in the polyneuropathy space, which tends to be more of the way that some of the variant forms present, as opposed to the wild type, which predominantly presents with a cardiomyopathy. But mostly, I think we're beginning to appreciate that there are mixed phenotypes. And the most important thing is, in patients who have variant forms, they tend to present earlier. And then we also want to make sure that their family members are aware, so we can have enhanced surveillance in this population. Now, not to forget the other hand, because I think it's important when a patient has AL amyloidosis, this is the immunoglobulin light chain form of amyloidosis, it's an emergency, and we want to make sure that they get to a hematologist as soon as possible. So if you have or you identify a monoclonal protein, I think it's important, especially for a provider, to make sure that you have a collaborative practice with a hematologist to make sure that these patients also are subtype, and also they can be initiated on treatment. In the last 10 years, so much has happened in the world of amyloidosis. We have great therapies now. So it's not much of a death sentence as people thought it used to be. And patients are doing better, they're living longer, and there's so many trials available that I think every patient should be given and afforded the best chance for management.
That sounds great. You covered a lot, so let me try and summarize and see that I've got this correct. Yeah. But the first step is to get a blood test, and you're looking for a monoclonal gammopathy.
Yes.
If there is a monoclonal gammopathy, then you want tissue. So you want a bone marrow biopsy, or you want a fat aspirate to type, is this AL or not?
Or not, exactly.
And then if that initial monoclonal gammopathy screen on blood testing is negative, then you're looking for, is it another type of amyloid? Exactly. So you're going to do one of those PYP, scans, nuclear scintigraphy. You're looking for uptake on that.
Yes.
And then if that gives you the answer, great. If that's negative, it can still be amyloid. And so if you're worried about amyloid despite that, then you go for an endocardial biopsy.
Absolutely.
Okay, good. I think I got that. And then you mentioned that if it's AL amyloid, this is an emergency. It's got to go to hematology, and hematology treats with their usual range of medications. The other types of amyloid, you mentioned that there's increasing treatment, but I think they still come to us in cardiology to get those treatments. So do you want to give us a little bit of an overview of what treatments are available, or who, how do we decide on these things? And I recognize the space has expanded rapidly, as you mentioned, in the last 10 years. So.
Yeah, very exciting though. So yes, so I would focus mostly on transthyretin amyloidosis, which is what we see primarily in cardiology, and where we've had a lot of evolution and treatment therapies being approved. But before I go there are a few types of amyloidosis, rare, but can still affect the heart. Unfortunately, in those forms of amyloid, we currently don't have therapies, but we do support those patients if they present with cardiac amyloidosis or symptoms. So that would be your serum amyloid protein A, and that you will see in patients with chronic inflammatory conditions. Then we have the ApoA1 and the ApoA4, which are hereditary forms of amyloidosis that can affect the heart. Not very common, but it's still possible. And those patients, we still manage their symptoms. Now, in the area of transthyretin amyloidosis, in 20 2019, we had the first class of drugs approved, which are the stabilizer therapy. And these are medications that bind the tetramer transthyretin protein and prevents dissociation. So earlier on, I described the physiology of amyloidosis, where you have a tetramer transthyretin, which in the body functions as a transporter of thyroxine and retinol binding protein. In patients who have the variant form of the disease, and the variant form of the disease also in the past has been referred to as the familial form or the mutant form, but the correct nomenclature right now is the variant form. We see that there is a mutation in certain sequences that can cause pathologic manifestations. So in those patients, we see a cardiomyopathy or polyneuropathy phenotype. On the other hand, we have the wild type patients in the past referred to as senile amyloidosis, but we see that in younger patients now. Then it was considered an old person's disease. And they've also in the past being referred to as either the senile amyloidosis, but now is referred to as wild type. Those patients don't have any described or known mutations. And current medical therapies manages both pretty well if you have cardiomyopathy. The first class of drugs, the stabilizers, bind the transthyretin protein and prevent it from dissociating into the monomers and not forming the fibrils that are very pathologic. So what happens is in the ATTRACT trial, which was the clinical trial that approved the first therapy, the stabilizer tafamidis was shown to bind these tetramer, and at 18 months we saw a drop in all-cause mortality and also in the rate of CV hospitalizations. Additionally, not only does this affect mortality, but morbidity. These patients improved in their functional capacity, they walked further, and the rate of their decline was less. Additionally, when we look at quality of life scores, those patients also did better. So putting patients on a stabilizer therapy has mortality benefit and morbidity benefits. And this, I think, is a win-win situation in this community. And in the last year, interestingly enough, now we have 2 additional drugs. The second drug is also a stabilizer, acoramidis, works similarly to tafamidis, and in the clinical trial was also shown to reduce all-cause mortality and CV hospitalizations. Now, this year, we have a third drug, and I think this is great for the community. Now, this is the first time a silencer therapy is approved in the area of transthyretin amyloid cardiomyopathy. Now, this drug was also shown to have mortality benefits and also CV events, which was defined as recurrent CV visits or hospitalizations. Now, that drug works slightly different. So vutrisiran, which is the recently approved drug, the new kid on the block, as I like to say, is a subcutaneous administered drug that is given every 3 months. And this is a small interferon RNA that knocks down transthyretin production in the liver. So with the stabilizer therapy I mentioned earlier, they bind already formed transthyretin, the wild type or the variant, and prevent further organ deposition and organ dysfunction. Now with silencer therapy, these drugs actually stop or knock down the production of the normal or the variant form of transthyretin, and in that way also prevent further deposition and organ dysfunction. And this is a very exciting time in the area of amyloidosis.
So that's great. So it sounds like the 2 major classes are the stabilizer of the protein,
yes,
and then now the ability to silence the genes that cause it.
Yes.
Definitely sounds very exciting and changing rapidly. It's hard for the rest of us to keep up. So thank you for sharing your expertise.
Yeah.
I guess we're coming to the end of our podcast here. Any particular words of wisdom you'd like to share with the audience, or anything else you'd like to add?
So absolutely. If you don't think about amyloidosis, we always say in our clinic that you more than likely in the last 6 months if you haven't diagnosed a patient, you probably missed one. So, now is not the time to miss a diagnosis. Patients are coming if you have non-specific symptoms, if you have suggestive imaging findings in the right clinical context, we want you to think of amyloidosis. And that's very important because now we have treatments for these patients. But also equally important is making sure we follow the diagnostic algorithm. So once you have a suspicion, the first step is to screen for monoclonal proteins. When you screen for monoclonal proteins, then you identify patients that you need to refer down the tissue pathway and maybe collaborate with a hematologist to make sure if there's immunoglobulin light chains, you type it, and those patients can be referred emergently for treatment. On the other hand, if there are no monoclonal proteins, then you want to proceed to a scintigraphy with pyrophosphate scan. And in these patients, if you have an equivocal finding on the pyrophosphate scan or negative, and you still have a high clinical suspicion, those are the patients that we also want you to refer for endomyocardial biopsy because that's important. Now, once you have the transthyretin diagnosis, it becomes important to identify, is this a variant form or is this wild type? Because now there's genetic testing. We have enhanced surveillance for family members because we follow the patient, the youngest patient, which is the index case, and that way gives us good guidance for the family. And for the wild type, we also know that there are effective treatments available. Now, I will round up by saying this, there's a very exciting research opportunity going, and it's now almost, I would say, a primary prevention clinical trial going on where we're looking at, is there any benefit to prophylactically treat people before they actually manifest symptoms? Because I think the most important thing in diagnosing an amyloid patient is recognizing it early, because the earlier we get patients on treatment, the better they do. Right now, what we have currently approved medications, they reduce the rate of progression, but they do not cause regression. There are exciting clinical trials in the pipeline that are answering that question, that how do we reverse organ dysfunction? And I think the next few years are going to be very exciting. So recognize the disease, screen the patients appropriately, refer patients that have monoclonal protein appropriately for tissue biopsy and collaborative practice with hematologists. And the other route, if the monoclonal protein is negative, we go down the scintigraphy pathway. And the most important thing is making sure that we get the diagnosis and we're sending patients for treatment early.
That sounds great. Thank you so much, Dr. Adigun, for all your expertise on cardiac amyloidosis and for sharing it with us. And thank you for taking time out from your busy schedule to join us.
I appreciate it. Thank you for having me. Thanks.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Vascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.